Well, thank you, Jennifer, for inviting me. And as she's sort of gone over, I've been involved in surgical health services research, and a lot of it being focused on big data analysis over the last decade. However, I've gotten to the point where I realize that there's a limitation to just doing big data analysis, that you've actually got to use that data in a meaningful way. And I think that's where informatics comes into play, and where I really see the need to define my career by becoming more involved in surgical informatics and using health information technology that can get data to the providers and to the patients in a way that's going to help improve their quality of care and outcomes. So I'll go over some of the projects I've done in the past, but first my research direction is really in this area of care coordination and transition. So I just want to first explain what that means. I have no disclosures to report. So I want to give you an overview of care coordination during transitions. The existing strategies that have been sort of published and defined in this field for medical patients, but where we can actually use some of the information that's been published and for surgical patients, and then where the role for HIT comes into play in terms of as I said, getting the information to the providers in the right place at the right time to help hopefully improve patient outcomes. First of all, what is care coordination? This term means a lot of different things to a lot of different people, and there was a working group sponsored by ARC back in 2007 that looked into this issue, and they found that there was over 40 definitions of care coordination in the literature. And so they put their heads together and came together with a working definition, which was defined as a deliberate organization of patient care activities and sharing information among all providers involved in a patient's care to facilitate the appropriate and effective delivery of healthcare services. So you can see, that seems fairly simple, but when it comes into reality, care coordination is a fairly complex process. And this schematic, which was taken from a recent New England Journal of Medicine commentary, really illustrates this point. For a single patient, this PCP over the course of 80 days had to coordinate care using phone calls, emails, scheduling procedures, office visits over 53 times for the single patient. As you can imagine, this becomes, for a single patient, this is a lot of work. There's all this information that needs to be communicated between providers, and a lot of times providers just don't have the bandwidth to do that. So how do we organize this information and the transmission and communication of information in an effective way? Because if we don't, ineffective care coordination leads to bad outcomes. I think this is well documented. That patients will get the wrong treatment, delays in diagnosis and treatment. Patients are unhappy when they don't get the right information. There can be medical errors and adverse events, increased length of stay, and then increased healthcare costs and utilization. And this last thing is really readmission, which has become a hot topic within the literature. And this revolving door, back into the hospital has really become something that healthcare payers and providers and patients are all taking note of, because it's readmissions are really a proxy for the quality of care coordination. If patients aren't getting the right care, a lot of times they're having adverse events and they're having to come back into the hospital. So readmission is something that people are looking at as a proxy for care coordination. Care coordination is really getting the attention of all the major healthcare oversight organizations in the country, because it relates to poor quality of care and also leads to increasing the cost of healthcare expenditures and utilization. The Institute of Medicine estimates that on an annual basis, $240 billion could be saved if we found out a way to make care coordination more efficient. So CMS, to this aim is sort of looking at different care models for making care coordination more efficient. And I think most of you might have heard of accountable care organizations, or ACOs. These are all looking at bundled payments for patient care. But also, there's meaningful use standards for care coordination, and these are now being integrated within our electronic health records. So this is something that's directly related to HIT. The NCQA has come up with 6 care coordination standards. The National Quality Forum has done the same, and ARC has put together a care coordination framework, which is right here, which is broken down into both broad approaches for care coordination as well as specific care coordination activities. And then they also look at how we measure care coordination. It can be at the patient or family perspective. It can be from the healthcare professional's perspective, and also from the health system's perspective. So each of these perspectives has kind of a different angle. I mean, so from the patient's standpoint, how satisfied are they with the care they receive, and as well as, do they get good clinical outcomes? From the, healthcare provider standpoint, it's, how well, are we making our lives easier to deliver care and not just duplicating services? I mean, in healthcare, there's nothing more frustrating when you go through the work to, order a CT scan for a patient when you find out the patient had it last week, and, you're basically just ordering a $2,000 study that could have, been avoided. And then from a health systems perspective, it's really, how do you get to this concept of value, where, value is the quality of care and outcomes, divided by the cost of care. And, doing this using healthcare utilization in a productive manner. So these are the broad care coordination approaches, and this includes teamwork, care management, medication management, patient-centered medical homes, and health IT-enabled coordination, which I'm going to focus on a little bit later. But again, this is part of what we think about in care coordination, and health IT is part of this. In terms of specific care coordination activities, there's many, and part of it is just making sure that patients are involved in their care. Communicating, sharing knowledge between providers and patients, assessing patients' needs and goals, and trying to deliver care that meets those goals, creating proactive care plans, establishing and monitored follow-up care plans, self-management goals, aligning hospital and community resources with patient needs. A lot of times, when we discharge patients from the hospital, it's how good of a job are we doing to actually recognizing what things can be done outside the hospital that can facilitate care coordination, and then also facilitating transitions of care. And this last care coordination process is really important for surgical patients. Given that surgical patients are really, for an episode of care, they're going between different care settings that, they're being referred to a surgeon, they're being referred to a surgeon that probably doesn't know them very well. I mean, in a lot of cases, they're meeting their surgeon for the first time. The surgeon has to get a lot of information about this patient, and then after their surgery, they have to communicate this information back to their chronic care providers, their PCPs, and so transitions of care are very important for surgical patients. But really, what is a transition of care? It's a set of goals or actions designed to coordinate and make sure that there's continuity of care for patients as they go between these different care settings. Or, another analogy is that, a transition is basically a throw and a catch between, two levels of care or two providers. Patients can transition within many different care settings or between providers. The most commonly studied is, going from the hospital to the home care setting, but there's also hospital to, acute care facilities, home to assisted care. In the hospitals themselves, you can go between, ICUs and hospital wards. Those are transitions. Between PCPs and specialists. I mean, these are all transitions because you're basically going from one care setting to another where people don't necessarily have all the information about this patient, and so it's how well is communication, transmitted for these patients between these different settings. Again, a transition of surgical care includes going from the community to the hospital, as well as the follow-up care, and this includes the access to get to a surgeon, but also the follow-up care and the coordination between the primary care providers, the ones that are taking care of these patients. In many cases for like 20 years, they're being referred to a surgeon who's just meeting them for the first time. They've got to assimilate a lot of information about this patient, what their goals, what their expectations, what their care needs are. And then after the surgery, they might have changed a lot of the care plan for this patient or the direction, or there might be things to follow up on. How well do they then communicate this information back to the primary care providers who are then going to take over the care of this patient and be managing them, for chronic care needs. Problem is with all these transitions is that we are used to working in healthcare silos where we each have sort of our roles and our jobs that we do, but we don't necessarily do a good job sometimes with communicating information between each other. And the silos are, as I've sort of defined, between providers. There's also financial silos, but also technological silos. I mean, we're not able to always access patients' information from their health records because our healthcare system is fragmented and we have different EHRs. I mean, every hospital has their own system, and how well are we able to interact with each other and access that information that's going to improve the patient's care coordination and possibly their outcomes. In surgery in particular, this whole issue of silos is important because, there's also, just kind of the background of surgeons and primary care providers. A lot of times they don't speak the same languages. Their goals and expectations for patient care are very different. Surgeons are, again, meeting patients for the first time. They don't always have all the contextual information about a patient's care needs. This is really, the pitfall of episodic care. And then there's also the communication problems with, who actually takes responsibility for the care when they go between these different care settings. I mean, I often, have primary care providers say, well, they get a patient back in their office after surgery and they've got this big wound, but they're not sure, are they supposed to be taking care of it as a surgeon? Like, who's actually responsible for the patient's care? And a lot of times these questions are what impacts, patients', complications, the need for readmission, and all the things that I've already discussed. Uh-huh. Well, when I say that, it's talking about providers don't always, they are very much in their own silo in terms of what the patient's needs are. So from a surgeon's perspective, they might say, okay, I did the surgery, all I really care about is the wound. Whereas the primary care provider, when they're thinking about the patient, they're thinking about, maybe their medication management or their chronic, their congestive heart failure, their asthma, all these other care needs. So, when we're talking the different languages, our perspective on, what's important to that patient's, that individual patient's care, a lot of times there's just a lot of discordance in what our goals or expectations for what the patient's care should be, what kind of care delivery they should be receiving. Yeah.
For example, how could a patient with chronic heart failure that's non-stable maybe affect the healing of the wound, for example?
That's an excellent point, and I think that in a lot of cases, the surgical providers, and I'm generalizing, but are not thinking about that when they're working with a patient. I mean, they are to some degree. They might be saying, well, this patient, they're diabetic or they've got renal insufficiency. These things are going to affect their wound healing, but a lot of times they're not assimilating all this information that is going to be very important. And so just that one factor, and I agree with you, heart failure, it can dramatically affect the patient's recovery, their ability to recover, and sometimes they're fairly tenuous, meaning that they're in sort of a steady state, but then you put them through an operation and they start spiraling, and it sort of leads to this cascade of events that ultimately either leads to a major complication, morbidity, or mortality. So.
Maybe this is also an area of research. It's not only the communication of what I need, it's the knowledge
Right.
that's shared
Yeah.
between, so that people don't really know how to work together sometimes
Right.
in the optimal way for the patient.
Right, right. Yeah, and this is something that we're trying to look at, and I'll kind of give some examples of a study that we're trying to at least hone down on some of these questions. So I think it's very appropriate. So, now when we think about transitions, the fact is that, I'm interested in surgical transitions of care, but there's actually been, a body of work that's been done in transitions for high-risk medical patients. And I want to just kind of discuss some of these strategies because I think they're relevant to surgical care and also health IT. But there are a lot of studies out there, and one of the sort of common threads is they're all very patient-centric. This is a systematic review that was done of looking at a whole host of different interventions that have been done to improve care coordination and reduce readmissions, and they're broken down by these three categories: pre-discharge interventions, post-discharge, and the interventions that help bridge the transition of care. So the pre-discharge interventions are designed around discharge planning, patient education, medication reconciliation, scheduling appointments at the time of discharge. Post-discharge interventions are all about the follow-up care. Do they see their PCP? Do they receive a telephone call, a home visit? And then the intervention bridging is all revolved around care coordinators, care navigators, transitions coaches. They're all sort of euphemisms for the same thing. And then whether there's continuity of provider care over the course of that transition. This is hard to see, but basically, this kind of shows the extent. There's been a lot of studies that have been done in transitions of care, And they kind of broke it down by whether they were a pre-discharge, post-discharge, and intervention, bridging the intervention. But kind of the important take-home point of this was that no single intervention that was designed to improve transitions of care or care coordination was actually effective in reducing 30-day readmission. However, if you bundled some of these different care coordination measures together, they actually were. So, if you're just looking at a single thing, it's probably not going to work. But if you actually look at several different things in combination, there's a good chance that they are going to reduce readmission. So there have been these bundled programs that have been put together. These are kind of the most common ones you might have heard of. The Care Transitions Intervention or Project RED or BOOST. These have gotten some attention in the literature. Some of them are designed for high-risk medical patients, such as people with heart failure that are basically frequent flyers of the medical system. They're constantly having to bounce back to the hospital. This shows just kind of the differences. A lot of these care transition bundled pathways. They have a lot of sort of the same features, but some are they're a little bit different. They all have sort of a person that's involved in sort of coordinating the care, whether it's a transitions coach, a nurse practitioner, a social worker, kind of a team work model. The intervention can range from a patient scheduled follow-up visit, a phone call, a home visit, a standardized protocol. I mean, there's a lot of different kind of combinations of these different bundled programs, but again, they've all been shown to be effective to some degree or another. Probably the most well-known of these programs was designed by Eric Coleman, who's at the University of Colorado, and his care transitions intervention, the CTI, is based on these four pillars of transitions care, and again, they're very patient-centered, meaning that the patient has their own health record that they take care of. They have their own, a lot of this is to make sure they have knowledge of their own, medications and self-management. They understand what the red flags are if something is going wrong, like when to contact their PCP, and then making sure they have scheduled follow-up. And then the person that helps make sure that they are meeting all these goals is their transitions coach, which is usually a nurse practitioner. They, after a discharge, they'll meet with the patient. They'll either make a phone call or a home visit, and this one care transitions coach will typically take care of about 20 patients at a time. And these programs have been tested at a lot of different hospital settings, and they've been shown to be effective. This is just an example of what a personalized health record might look like for a patient. Again, this is all done on paper because this all came out in sort of the mid-2000s, but you could see that this could easily be something that was on a tablet or in a computerized format for helping patients take care of their medications and sort of chronic care needs. But the sort of the take-home to all this is that this was a randomized trial that randomized 370 patients in each both the intervention and the control group, and you can see that it was the odds ratio was highly significant for readmission at 90 days and 30 days. Basically there was a 40 to 50% reduction in readmission from 30 to 90 days, and then 50% reduction in readmission within 90 days if it was for the same diagnosis that led to their initial hospitalization. So again, this led to sort of a lot of hospitals adopting these sort of care pathways. But the interesting thing is that this has never been adopted for surgical patients, so it's something that we've certainly looked into. So the question is, what can we adopt from these interventions to improve the care of surgical patients, which are they carry a lot of the same chronic care medical needs that people with congestive heart failure and kidney disease and whatnot, but you're also putting them through this episodic care of an operation. And so, again, it's a lot of times it's different providers taking care of them during that hospitalization, people that aren't familiar with their chronic care needs. There's a lot of sort of, opportunities for gaps and problems to occur. So if we go back to kind of look at the transitions of care interventions, there's two areas that I've recently looked at using Medicare claims. One is to look at PCP follow-up, and the other is to look at provider continuity of care. So early provider PCP follow-up was previously shown to be an intervention that was very successful in reducing readmission and mortality in patients with heart failure. And this was a JAMA article that was published back in 2010. As you can see, that patients who had early PCP follow-up had a much less likely event rate for readmission or mortality. So the question was, how do we look at patients who are sort of high-risk medical patients who undergo an operative procedure? So I did a study using Medicare claims where we identified patients that were high-risk medical patients who had undergone thoracic aortic aneurysm repair, which is a big surgery. I mean, it's a surgery that, we have to do a big thoracotomy. The patients are in the hospital for, usually over a week. It's a big operation. What we found is that, if what we did is we used Medicare claims data to look at this, and we had about I think it was about 1 million patients that we were able to look at for this combined study. But what we found is that we looked at whether they had the operation, and then we used Part B claims to define whether they had outpatient follow-up care with their PCP within 30 days. And the interesting finding was that patients who had undergone these surgeries and had a complication, and the complications were defined as, did they have a heart attack in the postoperative period, or they have renal failure or pneumonia, or one of these medical complications that would make sense that they would go back to a PCP. Well, those patients, if they saw their PCP, their readmission rate was 19%, versus if they didn't see their PCP, it was 36%. So it was highly significant. If they didn't have a complication, we didn't see an effect. And also, if we also looked as a control group, a lower risk operation, ventral hernia repair, and we found that, again, in low risk patients, low risk procedures, you don't see the same sort of effects. But the take-home message from this was, if we have these high-risk medical patients that are undergoing high-risk surgery and they have complications, having them see a PCP is very effective in reducing readmission. So the other thing that we wanted to look at was provider continuity. So this is an established metric for the care and treatment of patients with chronic medical needs, and it's defined by the Joint Commission as coordinating and maintaining care by the same providers before and after discharge from the hospital. And I mean, this has face validity, because you can think, a physician knows a patient's history from experience and can integrate all the things that are important for care coordination without having to go back and look at their medical chart and learn this patient, from sort of a new experience. So the question was, how do we study this from the perspective of surgical care? Well, first of all, there's been several studies that have shown that in high-risk medical patient populations that continuity of care is important. This was a study done by Elliot Fisher and the group at Dartmouth using Medicare claims, where they showed that patients who had heart failure and high-risk medical conditions, if they saw the same provider during, after their hospitalizations, they were much less likely to require readmission. So again, provider continuity makes sense, and there's data to support that. But the question was, how do you look at provider continuity for surgical care, which is episodic? Well, one way to do this is to look at, if a surgical patient gets discharged and has a complication, do they go back to the same hospital and see the same providers when they require a readmission? So, this was something that we looked at in a recent study that was just published this summer in Lancet, where we used Medicare claims for over 9 million patients that had undergone one of 12 different high-risk operations and low-risk operations, and we stratified patients by whether they went back to the same index hospital that they had their operation and saw the same providers versus going to a different hospital. And what we found is that patients that go back to the same hospital and the same provider when they have a complication and require readmission have a much less likely of dying within the hospital and also dying in 90 days. And there was a dose effect, meaning that if you go back to the same hospital, you have a mortality benefit, but if you go back to the same hospital and see the same providers, you have an even greater mortality benefit. And this was seen across 12 very heterogeneous procedures, from hip surgery to lower extremity bypass to craniotomy to open heart bypass to general surgery, colon resections. I mean, we looked at a whole spectrum of different operations. You can see them all here, and we basically did 2 different statistical methods for looking at this. We did an inverse propensity weighted model, and then we did a instrumental variable analysis, which is a way to basically do, for observational data, do pseudo-randomization where you adjust for unmeasured confounding. So that was important to show. But you can see that everything is on the side of favoring going back to the index hospital, and the mortality estimates really show that continuity of care for surgical patients is important and reduces your likelihood of mortality. This was sort of an important finding for us, because a lot of the quality measures in surgery are directed at, you need to go to the highest volume hospital that has the biggest, infrastructure for doing these complex operations. But, people don't really think about, well, if you have a complication, and a lot of these patients, for example, in vascular surgery, the need for readmission range is usually from between 15 to 20% of patients. So if you think about that, a quarter of all surgical patients that I deal with are going to have to be readmitted for some reason, and that's just across all hospitals. If you have to get readmitted and you are not going back to the same hospital, that can affect your outcome. So what we did is we also looked at, if you had an operation in a low volume center, it was actually more important that you went back to that same low volume hospital for your readmission than if you got bumped up and went to the large, tertiary academic medical center for your care. So this kind of told us, well, volume is important for the initial operation, but if you have a complication, continuity is more important than if you go to like the big hospital with all the resources and everything else. So kind of something that changed kind of the thinking about how do we regionalize care for high-risk medical patients, and what can we do to improve their outcomes. So the question now is where do we go from all this data, and this is kind of where I'm going with this talk is where does HIT and some other methods come into play. So again, the broad care coordination approaches are all designed around all these kind of broad frameworks, and they all are interrelated to some degree. The two things that I'm going to just talk about briefly is just the patient-centered medical home and the health IT aspect of this. So this is the patient-centered medical home. It's sort of a new framework or model for care coordination that's revolved around having a patient's care coordinated between the PCP and all the different specialists and ancillary providers that take care of a single patient. So in terms of specialists, surgeons are part of this kind of neighborhood of providers around a given patient, and it's really important to look at how do we coordinate care for patients that need to have a surgeon and then communicate that information back. And this is really kind of central to what I was talking about before. We are looking at this in the VA. In the VA, the medical homes are called the patient-aligned care teams. This is because they surveyed veterans and they said they didn't want it to be. They didn't want to be thought of as going to a medical home because it sounded too much like a nursing home, so they like the acronym PACT better. Anyhow, there's a specialty care center innovation that's located at our Salt Lake VA that's looking at this whole aspect of how do we coordinate specialist care for veterans between their PCPs and all the different specialists who take care of them. So we're using this framework right now for looking at this, and you can see, there's a lot of processes that you can use to evaluate the effectiveness and efficiency of care coordination. One is, how often are PCPs communicating with each other? What is the timeliness? Is there, measures of appropriateness of services or duplication? This is something that's big. How often are we getting the same, ordering the same labs from the same patient, within like, a 72-hour period where providers just don't realize that other providers have ordered the same things. And then looking at the outcomes, and I've already sort of talked about, preventable readmissions as being one, but also clinical outcomes as well. But the central thing to all this is, are we using, meaningful use of health information technology to help, arrange and coordinate all of these different, other measures? So, what is the role for health information technology in care coordination? I think it's very central and where we need to be moving towards. So I think there's three main things where health information technology can be sort of a platform, a technology platform that we need to focus on. One is to facilitate information transfer between providers and patients during transitions of care. Again, that's one of the central things I think that's important, but also providing information at the point of care. So providing information to those providers when they're getting a patient that they may not be familiar with, that would facilitate information transfer, their knowledge of that patient, and their care coordination. And then finally, getting patients the tools to communicate with their healthcare providers and to gain the knowledge that's going to be able to smooth their transitions of care and ensure that they get the best clinical outcomes. So the first area is information transfer between providers. So there's a couple different things that are out there. Kind of the magic bullet is this concept of having health information exchanges on both either a statewide or a national system, and these have been promised, but they've been very slow to materialize. And we keep hoping that the infrastructure is going to be developed within our lifetimes, where we could get on any computer, have Mrs. Jones, who just got transferred down from Wyoming, and look up all of her health information that goes back to her birth, and have all that information basically at our fingertips. But right now, a lot of times we're relying upon either health records getting sent down in like a packet of papers, which is very inefficient, or there's no information that comes down and we're simply relied upon the patient to relay their health information and background. Well, it is, but again, the meaningful use standards have not gone into play, and it's still a question of how well they're going to be used and how well providers are going to be able to utilize those to get the information. Well, they're starting to do that, and there is if you go into Epic right now, there is sort of this module that says it's the tab that's labeled care coordination. But there's several different problems with it right now. One is there's limited hospitals that are part of that. I mean, I think right now the only hospitals I ever are able to find information is from St. Mark's Hospital. But like if they come from Wyoming, Nevada, Idaho, which 60 to 70% of my patients all come from out of state, I don't have access to Sweetwater Hospital in Rock Springs or Portneuf in Pocatello. I mean, they're not on this platform, so it doesn't help. But it's just a slow progress. They can be, yeah. But some patients, they kind of, a lot of patients are transferred from these other medical centers, but some patients, they would rather have their medical care at the University of Utah. So they're happy to drive from Evanston or Rock Springs or these places. They actually recognize that they're going to get much better care if they come here than if they stay in their local hospital. So you even get the elective patients that come that it's the same issues. But emergency transfer patients, it's a big issue because a lot of times they've got an acute sort of medical or surgical emergency, and you're trying to assimilate all this information about them, and there's no way to do that, and you have limited time to do that. So it's one of the big problems. Telemedicine and video conferencing, this is something that's being developed and is, again, I think is making progress. I mean, we have, for example, the burn surgeons here have a telemedicine clinic where, they have all these burn patients that are sent here, but then, reside outside of the state of Utah, and they can do, weekly or monthly clinics with these patients while they, reside in their outside, communities, and it really, saves them from having to drive all the way down to Salt Lake every time they need to, see a provider. So there are a lot of these telemedicine clinics that are coming up, and I think, depending on the kind of care that the patient needs, I mean, some things, providers just need to be able to touch the patient and look at things directly, but some things, can be done, vis-a-vis teleconferencing and whatnot. Another thing that's being developed, and this is actually in the VA, is Scan Echo, where you set up these video conferencing between specialty care providers and PCPs in the community. So, for example, a PCP, that's up in like rural Idaho can contact say like a dermatologist here at the University of Utah and say, I've got this patient. Here's a picture of this lesion on their skin. What do you think about this? Does this patient need to be sent down to Salt Lake, or can I just watch this on my own? So those kind of things really do facilitate healthcare utilization and reducing things that are actually important to patients. But one of the things that I'm very interested in is within our own EHR, how do we improve the exchange of information and communication of these these goals and expectations of care that each of us have? And this is kind of back to what you're relating, Jennifer, is how is knowledge transferred between providers and between care settings? There is this concept of shared cognition that I think provides a model for how to look at this, and this is actually part of the new generation of EHR or CPRS in the VA, which is called Vista Evolution, is actually going to be based on this concept of how well do providers share goals and expectations for care for a common patient in a sort of a dynamic versus a static way. We're looking at this within ways to develop tools for Epic, but part of this is first you've got to actually understand where's the concordance of goals and where's the discordance of goals. And when we talk about goal alignment, it's how well are they joined. Control is how well are they organized, and coagency is how well is there evidence that different providers are actually are working together to try to address these patient needs. So we're doing a study right now, and this is the team that I'm working with, which is including Guilherme and also Stacy and Charlene. And we've got funding to do a study where we're interviewing primary care providers that are referring patients to surgical providers, and we're interviewing them to assess, for these, patients that have been defined as being high risk, medically complex, and older. What are the things that need to be transferred for this given patient, from this referral process, which is, you're referring a patient with all these care needs to a different provider that might not understand the patient's contextual background and where they've been. Are they on what kind of trajectory are they from a medical standpoint? So we're doing these interviews that are first looking at the PCP's goals and expectations, but then looking at the surgeon's expectations, and specifically looking at things that relate to cognitive abilities, functional abilities, things that might relate to frailty, risk factors that might be important for a surgeon to know before they're going to schedule a patient for this high risk operation. Is Grandma Jones, is she, how well is she doing at home? How well does she have a social support system that's going to allow her to thrive after a big operation? These are things that aren't commonly communicated to me. When I see a patient in the clinic for the first time, I'm just going in and meeting the patient, and hopefully they've got a family member or a caregiver that can help sort of bring some of the pieces together. But in many cases, all this information is just me to sort of assimilate based on their chart, the way they look. And hopefully I'm making a good professional judgment that this patient's going to be able to tolerate this big operation that I'm going to schedule them for. So I think it's really important to get to the bottom of some of these issues. So the second issue is how do you get information to healthcare providers at the point of care? There's a lot of opportunity to do this using dashboard, mobile device applications that can help making clinical decision making, improving the workflow planning. Part of this is that all this stuff, when we talk about dashboards and whatnot, we need to think about doing this in a way that doesn't increase work for the providers. Because if you try to tell them they've got to use a dashboard for a patient that makes it so that they've got to spend an extra 5 minutes to try to figure out the dashboard or to extract the information from it, they're just not going to use it. So we've got to be thinking about this in a way that is very kind of ergonomic. But predictive analytics is something that I'm personally interested in looking at, and that's how do you risk stratify patients at the point of care and decide what sort of care plans do they need. Also, can you identify people at high risk for adverse events before they occur? And one of the ways that we're trying to look at this is this safety trigger algorithm. That's been developed by a person I'm working with right now, David Clausen. This was done back at Intermountain Healthcare back in the 80s and 90s, but basically using data from the EHW or Enterprise Data Warehouse that signifies when a patient's either at risk or has had an adverse event. And here's an example of a patient who, again, safety triggers are combining information. So this patient's on insulin and they're found to have this low glucose. So it's using the combination of different data points to say, has a patient had an adverse event or are they at risk of having an adverse event? And you can then use this to create sort of a predictive score. What is their risk of having an adverse event from this point forward? I'm very interested in using this to identify patients at risk for healthcare associated infections. For surgical patients, surgical site infections is one of the biggest things that we have to deal with, and it's how do we use the information that a patient comes in it's all in the EHR. How can we better risk stratify patients for having these events before they occur, and design care pathways that are for low risk patients versus high risk patients, because we sort of don't really think about these things right now, but if we did sort of had a higher sort of hey, this patient's got a 66% of having something bad happen to them, can we improve their discharge planning and all these other things. That's the other thing that sort of hit home, is that a lot of the complications that happen in surgical patients, they actually get diagnosed after they've left the hospital. So, surgical site infections, about 50% of them get discharged after they've left the hospital, not before. So we don't, it's at the time of discharge. How could you utilize a dashboard to say, Mr. Jones or Mr. Allen's got this high risk for having this adverse event. If we send him home right now, what do we need to do to actually reduce these risk factors? And that's where I think this concept of predictive analytics is very, very important. The final thing just to hit on is patient-facing health technology tools. And this can include anything from web-based management, like MyChart, which we're finding patients really like enjoy getting on their MyChart and having the information and being able to communicate with the providers. But the other area is these mobile devices, smartphones, tablets, these applications that allow providers and patients to communicate more effectively. And there's a lot of these applications out there. I mean, there's more applications that are based on this kind of patient-provider communication that you can't even list them all. And the question is really, who's going to be the platform that people are finally going to adopt. The one that was actually designed at the University of Utah is called MobiMD, and they have gotten the go-ahead to try to integrate the information from this platform into Epic. But there's just, it's just a slow process. I mean, it's been over a year, and I just don't see it moving that quickly, and that's part of the problem with all this. But I've been using this smartphone app to give to my patients that I'm worried that they're going to have a wound breakdown or a wound infection. So I've been identifying these patients. I've been saying, hey, can I put this software app on your phone? As long as they've got a smartphone, it works. And here's an example of a patient that we had to do. This is a transmetatarsal foot amputation, and you can see, this was a diabetic patient. The wound's at high risk for breaking down or getting infected. And I said, I want you to take a photograph of this wound basically every other day for the next 2 weeks and send them to me. And that's what he did. And basically, he saw some redness. He saw this kind of black scar. He was worried. This is what this wound should look like. I mean, I wasn't worried, but if he didn't have this software app, he would have been going back to the ED or would have been coming back to clinic. I mean, he was like very anxious and nervous about it. But the fact that he was able to send these photos, on this secure platform, and this is a PHI secure platform, and we were able to look at it and then just basically send him an email back saying, hey, wound looks fine, don't worry about it. That redness is fine. If it gets worse, you can do this communication that is very effective. So, in summary, surgical patients are high risk for all these problems during transitions. There's a lot of different evidence-based strategies, but really, health IT, I think, is where we need to be going in the future. I mean, there's just a lot of ways that we can improve care coordination from an HIT perspective. And I think the things that we need to be sort of focusing on is, building these information tools for the EHR that are really dynamic. I mean, a lot of times, information transfer is all static, but, if you could have, say, a tool that was built on, something akin to a cloud-based platform that providers from different care teams can basically, define what the goals of care, their goals of care are, and we can look to see how concordant they are and look at this in real time. And that's really what we're trying to develop as part of that project I described. The next thing is this concept of predictive analytics, which I talked about. And then, really thinking about this all within the context of how do we do this in a way that doesn't increase clinician workflow, but actually decrease it, because that's really what we need to be striving for. And then it's really, we need to think about how to get smartphone applications and other things that can help improve care coordination into the patient's hands. This can be difficult for some patients. I mean, even though, all the statistics say that, X amount of, over 60% of patients have a smartphone. I mean, a lot of times they just, they don't know how to use them, and it's a lot of times it's just getting them to adopt this technology in a way that's going to help, their care and is meaningful. So, anyhow, that's all I have, and happy to answer any questions or go into any more detail. Yeah, so the technology, well, it was designed by an acute care, a trauma surgeon here named Ram Narula, and I know that they're using it for all their trauma patients. The technology has actually just been recently sold to a company called Silverview, which is based out of Salt Lake, and what they're trying to do right now is build a platform for tablets that they would basically sell to skilled nursing facilities and nursing homes to help coordinate the care, of all the patients that go to SNFs. And so they're trying to use this technology they've developed, with including the pictures and all the discharge plans from the inpatient setting to allow the SNFs and the nursing homes to have all the information, because that sometimes is one of the problems. Is the patients go to a skilled nursing facility and they they get kind of these one-page, nurse or these discharge summaries, but they don't give a lot of the contextual information about the patient's, care and what happened in the hospital and what the plan is. So, hi. Right. Right. Yeah. Absolutely, and that's a nice way to sort of bring it all together because all these strategies can be overlapping and they can be intertwined to a large extent. So the predictive analytics, I think, absolutely, you need to be able to first use that to predict what patients are going to benefit the most from these interventions. So absolutely, I mean, is it effective to try to target low-risk patients for a lot of maybe interventions that might cost a lot and not actually have the benefit. So I agree with you 100%. It's how can we use that to focus our attention on the patients that are really going to benefit the most. So, but I also think there's an element of another area that I think is important is this concept of care coordinators and navigators and maybe having those be the liaison between the patient and the care team that has the technology that can be the one to sort of integrate that technology for the patient. So, a lot of patients, and this is some of this has been based off of we've done some focus groups and looking at what patients kind of what they want, what their expectations are, and a lot of them like the idea of maybe having a second sort of person. And again, this is really more designed for the high-risk patients, but having a care navigator help them through the episode of care, both from an educational standpoint, but also if there are warning flags, that they're the ones that can kind of recognize it early and be the one to contact the care team versus the patient, which sometimes that just doesn't happen. Mm-hmm. Right.
Life and what the barriers are and all these different limitations and all these different drugs. And the surgeon has a very in-depth knowledge. Is it really possible to share goals? I wonder about that. And what I think is that the reason I don't believe that it's possible, really,
Mm-hmm.
is to share them. I believe that it's possible to be aware of them.
Absolutely. I think that's a good way to phrase it.
Because you have to think deeply.
Yeah. Right.
And then bringing people together to make decisions.
No, I think, Jennifer, I think that's well put. It's more the awareness of the goals, and one of the things I think that we've at least found in some of these interviews is just the recognition of what the roles and responsibilities are, because that's sometimes one of the biggest issues is not understanding, what am I responsible for this patient, or what does the other provider need to know about this patient that would be informative, which would help their decision making, So we're I think there's a lot of elements to this, but I agree with you. It's not. I mean, there can't be this shared goals, but at least you're aware of the same goals, and that this is what they're worried about or what they think is important, but you could still see having a dashboard where these goals are at least defined, and then at least you have a better contextual information for what the primary care provider is thinking about this patient when they refer the patient to you. Yeah.
Yeah, I think in our first interview, things that were kind of striking to me was awareness of goals, needs, plans, and even preferences in terms of workflow, communication, how people work.
Yeah.
What's the best way to communicate with this person? When do they like to communicate? How do they like to receive these kinds of stuff? It is very dramatic from people in finding a big mismatch in terms of what I expect, what I think, and what the other individual has to
Right.
think.
Yeah. Yeah, I know. I mean, absolutely, man. It's been very kind of eye-opening.
HR people, there's a notion of we hear in the media, in the news, especially outside in healthcare research, that EHRs are about technology silos and people using different EHRs. Well, EHRs, even the same EHRs and the same
Yeah.
institutions have huge silos because people are not necessarily reading to each other documentation.
Yeah.
Great example.
Yeah, or even if you're reading a lot of times I'll open up a note from a primary care provider and they're using all these acronyms. I don't even have a clue what they're talking about. I'm like, what is this? And it's like I'm spending 5 minutes trying to Google these acronyms to figure out what are they talking about. They've like condensed their note, using acronyms to the point where it's like you can't even interpret it. So there's a lot of these issues that I think from a workflow planning aspect is very important, and we need to, again, I think the main take home is that we need to figure out a way to make work more efficient for the providers so that they can make the right decisions and not, make the wrong decisions